Hello, and welcome to your OBGYN Clerkship. I'm Margot Ellard. I'm a certified nurse midwife and women's health nurse practitioner. This video focuses on basic orientation information. Please feel free during your clerkship to ask any and all questions you may have regarding any aspect of your training. Keep in mind the current COVID situation means things may quite literally change daily, and we'll make every effort to keep you updated. Today we will introduce GYN triage, OB triage, labor and delivery. In OB-GYN, in addition to the attendings and residents caring for patients, we have nurse practitioners, certified nurse midwives, and physician's assistants. We are all high-risk specialists as well as faculty. We will all be seeing patients and working with you. The advanced practice providers also participate in your reviews. We are all committed to giving you the best experience we can. Feel free to seek us out to assist you. If you're interested in pursuing OB-GYN as a career, welcome. Let us know. We're happy to help you gain as much experience as possible while you are here. If OB-GYN isn't your thing, keep in mind that this area encompasses many specialties you may have interest in, such as derm, psych, trauma, endocrinology, surgery, cancer, neuro, medicine, infectious disease, drug abuse, emergency medicine, to just name a few. We encourage you to participate in those areas while you're here. Some general considerations for all areas. Do not bring anything to the hospital you would be sad to see disappear. These areas are not controlled and we can't keep your items safe. The student cubbies are small. Don't bring large amounts of stuff or you may be tripping over it. There's a staff lounge with refrigerators and a microwave. These are yours to use. Please make yourselves at home there. If you become ill or have an emergency come up while you're here, please come tell a resident or midwife and we'll help you. At the beginning of your shift, introduce yourself to us and let us know if there's something you specifically need to do. At the end of your shift, come to the resident or midwife and tell us it's time for you to go. We want you to leave on time. We will not be keeping track of your schedule. So tell us and we'll be very grateful. If you have a special interest in a patient and desire to stay, great. If you've arranged with Dr. Nelson to do makeup time, great. Just let us know. I can't stress enough, please keep your voices down. You will be discussing the most personal information a patient may ever have in their lives. Abortions, STDs, drug abuse, partner abuse. Our physical areas frequently have no sound barriers, and the patients, all of them, are listening in. They do hear information about themselves and other patients, and on occasion have complained about it to the hospital or misconstrued what was heard. Please keep their information private. We have many language barriers. Language should never be a deterrent to you seeing a patient. We do have translator iPads. I don't personally use them. I use my cell phone. I call the translator number. It's located in triage. Ask anyone, they'll show you where it is. I put it on speaker and away I go. Please remember to get the translator ID number for the chart documentation. Oftentimes you have to ask again because you can't understand them, but please just get that number so it can go in the chart. Bullet point, clearly introduce yourself to every patient every time with your full name. Include that you're a medical student and that you will be present during their care. This is a must do. I spoke to a recent med student. Her advice to you is introduce yourself to everyone, the nurses, techs, doctors, residents, patients, everyone, every time. A rare patient will ask for no students. It's not a problem, no worry, it's okay. All of our areas have sleep lab as an option in the computer header. We use this to designate which medical student has signed up for a particular patient. We will try and be aware of that and communicate with you specifically that something is happening to your patient. Your patient's going to the OR, your patient's getting ready to deliver. Whatever's going on with that patient, we will try and get a hold of you and let you know. Currently, there's one student at a time, so you might consider putting your cell number there as well as your name. It always happens. As soon as you go to lunch, you go to the bathroom, the patient's going to deliver, and again, we'll try to communicate that to you so you can be there. Perhaps most important, please make yourself present and available to us and be self-directed, seeking out patients and experiences. Hang out at the work counters in OB. If you're in the student cubby with your head in a book or a computer, you will miss learning opportunities. An OB patient can arrive, be evaluated, taken to a delivery room and delivered, and you'll never know she was there. It can happen that fast. GYN triage and OB triage have a similar patient intake flow. The patient presents to the admission desk out front or to the nurse's desk. The nurse or tech greets them, takes the initial info and complaint, then takes them to be weighed, to the bathroom, gets changed, they give urine, they go to a bed, or if you're in GYN, they'll go to the waiting room. The nurse or tech needs to follow the steps to start getting the needed info into the computer chart so a visit can be created, and then the provider can begin charting and orders can go in. You can follow the nurse to the bedside and listen to begin your assessment. History taking. Every patient either gets their history reviewed and updated, or they've perhaps never been seen before and they need a full history. If you can see the patient has had their history done repeatedly at recent visits, in clinic, it's been done over and over again, you can quickly confirm with them any changes. If the patient has never been seen before, please obtain as complete a history as you can. Do not interrupt the nurses during their interview. They usually go as fast as they can. If the nurse is delayed getting to the bedside for their interview, you can go in and begin yours. But if the nurse then comes in during your interview, please stop and allow her to do hers first. When you've completed your interview, gather your data into a concise presentation in SOAP format. It should take no more than 7 to 10 minutes max to complete your interview. If you need to, set a silent timer. If it takes you longer than that, you need to figure out why. What is SOAP format? Do we really use it? Please take a picture of the wall in the conference room. It's important enough that it is on the wall for everyone to learn and to do. It's a skill. Listen and check out. This is the format that everyone uses to hand over patients. Attendings do it, residents do it, the nurses do it, the midwives do it. It's what makes our world go round. What is SOAP? Subjective, chief complaints; objective, what you see or learn; assessment, what you think's going on; and your plan, what are you going to do about it? When presenting the patient, only include history pertinent to the current situation. If they broke their leg in 1982, that's not pertinent typically to our situation. If you've obtained new information that we've not known before, please point that out to us. If you're confused, it doesn't make any sense to you, you don't understand why this patient is talking about something, please again, bring it up to us. Very often you've picked up information that changes the care of that patient. Your concise patient presentation is then given to a midwife or resident. It should take 1 to 2 minutes max to make that presentation. I strongly encourage you to do those presentations so well that you can do it in your sleep. It will serve you well your entire career. GYN triage is just a little bit different. GYN sees pregnancy under 16 weeks and non-pregnant women with a wide range of GYN concerns. The patients will be waiting outside the main doors. When you see a note pop up in her computer chart that says GYN EC nurse intake, you know the nurse has completed their portion and the patient is ready to be seen by you or a provider. Read the nurse's note. It can have lots of useful information to know before you see the patient. If you move a patient into a room for an interview, please show that on the computer board, tell a nurse, let somebody know. For example, if you put her in exam room 1 or you take her back to the waiting room, that's where we're going to look for her. That can be very helpful. We may think the patient left the area without being seen when in fact you are interviewing her in a room. At the end of your interview, see if an exam room is available. If so, the patient can go there. If not, they wait in the waiting area. You then present your patient to the resident or advanced practice provider. OB triage is very similar, except that we try not to ever have a patient in the waiting room at any time. The ideal is that all patients will go directly to a bed. We will put the patients on the fetal monitors. You should be doing ultrasounds. We'll show you as we go. Please ask for assistance. By the end of your rotation, you should be able to determine fetal presentation, cephalic or breech, location of the placenta, and that we visualized cardiac motion of the fetus. Please do not do an ultrasound without a resident or midwife confirming what you saw. Please clean the probe and wipe down the ultrasound machine when you're finished. Hopefully you will do speculum exams in both areas. We know for many of you, it's been some time since you used the equipment, and for many students, it's the first time without a professional model. Spec exams are invasive. Please review the procedure before arriving to refamiliarize yourself. We have lots of kits you can practice with beforehand, so you are calm and comfortable when you do it. Know your glove size. I encourage you to try on different sizes. I can wear a 6 for an hour or so, but I need a 6.5 if the time extends because my hands will fall asleep. Ask for spare gloves to try on. We have plenty. Closed glove gowning is used for deliveries, not open glove. That's used in the OR. We have extra gloves and gowns and encourage you to practice the technique. If it takes you longer than 60 seconds, you need to practice, or we recommend that you gown up in advance. We encourage you to be at the bedside with your patient during pushing, especially as the patient is getting closer to delivery. Seeing the work needed to push out a baby is a valuable experience. If you need to step away, ask the nurse assigned to the patient what she thinks. She is likely to know more about when that baby is coming out than anyone else. You can ask if going to lunch is a good idea or if it's a good time to gown up. If you're already gowned and gloved when the residents come in, you may do more than just catch the placenta. You might just catch a baby. The operating room. There are specific procedures to be followed when going to the OR. Do your scrub when you begin your shift. Pick your patient and know when she's going to the back, in other words, to the OR. Introduce yourself to the circulating nurse. The patient can't move to the OR without the circulating nurse. So if you stay in touch with her, you can't go wrong. Before you actually go to the OR, I recommend you blow your nose, empty your bladder, and eat something. You don't know if you're going to be in there for an hour or 5 hours. Go to the back with the patient at the bedside. Anesthesia is going to do the epidural. The patient's going to be laid in the surgical position. The drapes are going to be put on. The prep is going to be done, and then the surgery begins. There's lots to see with all that, so please stay with the patient. Be sure you introduce yourself to the scrub tech. The scrub tech and OR nurse know you're a student. They control the OR. Look for them. They will help you. They will tell you when to scrub, when to get gowned. They'll help you get gowned and gloved, tell you where to stand, get you a standing stool if needed. Do not put your gown and gloves on the back table. Do not reach for instruments on the back table or Mayo stand. The tech will hand them to you. Don't be afraid of contaminating something. It's okay. Do be afraid that you don't know that you did it. It can be fixed. It's okay. If you contaminate something, say so. It's okay. The scrub tech manages the sterile field. It's their stuff. Let them do their job. It's okay. If you need to step out of a surgery, you feel sick, or it's time for you to go, simply say so. You can scrub out if needed. It's okay. Don't wear shoe covers out of the OR. It's not okay. So one more time, welcome to OB-GYN. We're a fun group. We love to learn and to help you.
Good morning, I'm Tony, and I'm Scrub Tech here on Labor and Delivery. I'm going to give you a quick overview on what to do for your morning scrub, first morning scrub of the day. And this should be accomplished sometime in the first hour that you're here, just to be ready for a case, because you never know when surgery is going to happen. So you get your first scrub done. And so we have a couple of different soaps here, Betadine and Hib Cleanse. It's a personal preference. If you have a sensitivity to one, you can use the other one. And you'll grab one of these. I wanted to say that before you do your scrub, make sure you take care of all your personal things. Make sure you've eaten. Make sure you go to the bathroom, because one time you go into a surgery, you could be in there for 30 minutes or 3 hours. All right, I'm going to open up this soap here. First thing you'll do is wet your hands all the way up to your elbow. You're going to grab, you'll see in here there is a nail cleaner, so if you've been working out in the garden, then you can go ahead and clean your nails. Personally, I actually never have done this. I always just throw this away, but you can clean your nails first. All right, so here's a soapy sponge. You can see the red, that soap on there. You just want to get that wet. Activate the soap, and then you're going to start scrubbing your hands. Again, this is 3 to 5 minutes. You're going to scrub from your fingertips all the way to 1 inch above your elbow, paying attention to all the different surfaces all the way around your fingers, palm. And again, this is 3 to 5 minutes, but there's nobody watching you, so it's on the honor system. If you need more water, just turn the water on, get some more water. There is soap here available with a pump. You can just add some more soap, and you generally will add more soap and water. Again, you can just add it and continue to do your scrub. Once you do one hand, you're going to switch. Again, the same thing. If you need more soap or if you need more water, you can get that. And then you'll just continue to do the other hand, again, paying attention to all the surfaces, all the way to 1 inch above your elbow. Then you're just going to discard this. Important thing to say then, if you've done your scrub and you're going to come in here and do your rinse, if you touch something, then technically you need to start again. But we didn't touch anything. So we're going to rinse our hands. You just start at the beginning. Start with your hand. You want to keep your hand higher than above your elbow, and just go through. You get as much soap as you can, and if you need to get more, you just go through again. Same thing with the other side. Turn the water on. And all the soap is off. If you're going into the operating room at this point, then you'll just go ahead and go in. The scrub tech will give you a towel. You'll dry off. If this is your first scrub of the morning, then you just go ahead and grab some towels, dry your hands, and continue on with what you were doing. You want to do the AVIGUARD also? So if you've already done your scrub of the day and you're going to go into the operating room, the scrub tech has already told you to go ahead and do your scrub. Then you can come over here and do the waterless scrubs, AVIGUARD. It has a pump here. I say you're going to use 3 pumps of this. And again, it's for your hands. It's the same area that you're going to do for your scrub. You're going to do your hands and rub this in all the way to your elbows. It is alcohol based and it should dissipate. When you're going in the operating room, you go in there just like your hands are wet and continue to rub and scrub until you present yourself to the scrub check. Thank you.
I'm now going to demonstrate closed gowning and gloving. You'll be responsible for having your gown out. You can ask your nurse to help you put it on the table. You will have your gloves available. You can either have them placed sterilely on the table with the assistance of your nurse, or you can have them in a non-sterile area that you're able to access so that you can put them on. Once you pick up your gown, you're going to pick it up from the fold. You can see that there's a two-color demarcation on each side. That tells you where the armholes are. Once you find those, you're going to open up your gown and start to put your arms into the holes. Those are the armholes of your gown, letting your gown fall forward and not contaminating your table or anything else, either with your gown. I'm going to pull the gown on. Closed gloving, you never see your fingers. You should never see your fingers in any of this. Open gloving is in the OR. Your tech will help you with that. You're going to open your glove packet. These gloves are actually placed in this pack in a way that helps you put your glove on and have your thumb in the correct position. Pick up your right glove with your left hand, flop it over your hand with your cuffs, open up the hole, start to place your hand in. Use your cuff of your left hand to pull the glove over your wrist. If your fingers don't exactly line up initially, that's okay. You can straighten them out later. But if you put it on that way, your thumb of your glove will be in the correct position to go on the thumb of your hand. With your right hand, pick up your left glove, flip it over your wrist in the same manner. You're going to open up the hole where your fingers go. Tuck your fingers in with the cuff. Use your right hand to pull the glove over your wrist, and you can start straightening out your fingers. If the fingers are not correctly in the finger holes of your glove initially, that's okay. Even if it's not quite right, you can still use it to put your left glove on. Then your left glove is available to put your right hand on correctly. You can straighten out the cuff if it's bunched up, and it's going to annoy you when you're in surgery for several hours, but your cuff should never come above your glove, because that's not this is now a permeable, moisture permeable, non-permeable surface, and you don't want to show your cuff because that blood could go straight through that. Now I'm going to have somebody come and get my shoulders. Just you can back up and say, could you please get my neck, and they'll Velcro the neck. I generally choose not in a delivery to have the back tie done, just the tie on my shoulder so it's not folding forward. Okay, once you've done your delivery, we're going to presume there's some contamination in the front of your gown. And of course, your gloves will be contaminated. It may be very contaminated, a lot of blood. We don't want to show anybody else or contaminate anybody else with that. You're going to remove your gown and your gloves. You're going to grab your gown with your gloves, put your shoulders in as one way in order to pop the Velcro around your neck. And you're going to carefully roll this into a bundle, being aware that anything that's bloody and contaminated on the outside of your glove and your gown now end up on the inside, where you can roll it up, and this entire bundle with the blood inside goes into the trash. Now we're going to go over the back table. This is the table that's set up in advance of the delivery. The nurses set it up. Hopefully you've been in the room pushing with the patient and you can watch them set it up. If not, the first time you see it, maybe when you go in the room to deliver the patient. It's covered by a big blue drape. That drape is removed in a sterile fashion. Typically this drape is laid on the floor at the patient's foot, where you're going to be standing on it. The resident will stand on it to catch any blood or fluid that goes on the floor to help contain contamination. All of the tables have exactly the same equipment. The nurses set it up a little bit differently, so it may not look exactly like this, but all of the numbers will remain the same. Perhaps you've already put out your gown and glove with the nurse in advance. If not, this is a place that you can put them, if you can put them on the field sterilely. There's 2 gowns. One is for the resident. One is for the attending or faculty person that's assisting them. There's a number of blue towels. These are garbage. They do not get washed, so you can feel free to put those in the trash. Don't worry about it. There's another big drape. We may or may not use this. Sometimes it's laid across the entire patient. There's 2 basins. One basin is used to wash. Many times there'll be some soap that the nurses put in with some water and a number of sponges so that you can clean before if you would like, and certainly afterwards. There's another basin with a variety of things in it. It has a bulb suction for the baby, which you can hand off to the nurse. It has a hat for the baby. Oftentimes these are already gone because the nurse has taken them. It has a little blue box. These are used to put sutures in, the suture needle in, so you can keep track. You never want to leave random suture needles on the table. It's dangerous to you, certainly dangerous to the nurses. So they're actually stuck in here so you can keep track of them. There's 2 blood tubes. Typically the nurses will already have these and you won't see them. There is what's called a vacutainer and a syringe. These 2 pieces go together. You will be using these. These are where you collect your cord blood. To put them together, you're going to pull the plunger out of the syringe. The plunger part is now trash. The part with the numbers, that's where you're going to collect your blood. This vacutainer is a standard vacutainer. It screws onto the end of the syringe. You will be putting your cord in there and collecting blood. Usually 7, 8, 9, 10 to full is sufficient. There's 1 cord clamp. These are one-time use. It's already been clamped, so there's 1 yellow cord clamp. There will be 2 under the buttock drapes. Let the nurses, let the residents help you put these on. We're doing 2 as we're trying to do quantitative blood loss counts rather than estimated blood loss. So that's what those are used for. There's 9 instruments. You don't need to know what they are. What you need to know is that there's 9. If you ever count and there's not 9, that needs to stop. We need to figure out why. And there's 10 small laps on the table. That's everything that's on the table. You can do the count with the nurse. The residents will be very happy for you to do that, but it's done with the nurse. The first thing you want to say is, once you're gowned and gloved, we're presuming that you're gowned and gloved and ready to go, you can say whether the residents are there or not, I can do your count. It's an out loud count. You want to do it with enough voice that everybody can hear you. You're going to say, okay, we're going to count the instruments. Ask the nurse, yes, we can do the count. She'll probably say yes. I'm going to count your instruments. 1, 2, 3, 4, 5, 6, 7, 8, 9. We have 9 instruments. Now I'm going to count the laps. You can see that they're put out in a way that the nurse can actually see each lap. They're not put out in a stack, because then she can't tell, are those actually 5 or are they not? So they're laid out where you can see each lap, and you will count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 laps counts correct. I encourage you to notice that when you're doing this count, even if there's multiple people in the room, there's some busyness going on in the room, the nurse will be trying to see you actually do this. One of her jobs is to actually see with her eyes that she's seeing each instrument, each lap. She is not going to take your word for it. So be courteous and kind of see where she's at so that she can see this with you. If you've done this with the nurse, when the residents come in, you can say, I've already done the count with the nurse. The residents will be pleased. The nurse is your second check, so it's fine. You can go ahead and do that count. The count will be done exactly the same after you're done with the delivery to prove that there's 10 laps, none are left in the patient, and there's 9 instruments, none are lost or left on the bed or, God forbid, inside the patient. The 2 buckets, one typically is going to have a space for you to put, this is going to be for you to put your placenta in. The other one again is for you to wash. The top goes on the one with the placenta. Once all of the delivery is done, this is your wash water. All of the instruments will go into that liquid. Of course, your count has been done, and we want them open. So if any of these are clamped, you want to open them. That allows water to go into the hinge of the instrument so that blood isn't caked in there. It makes the sterilization of these instruments much easier for the techs. Leave them open. If there's any blood that's crusted on them, it's really stuck on, please do feel free, even if it's a bloody sponge, to give them a little bit of a wipe down so that they can start soaking. The nurse also has a red bucket. She may ask you to gather all of these and put them in the red bucket for her. She may not. Just follow her lead. She'll tell you. Delivery of the baby. The delivery of the baby is accomplished by the resident. The baby is handed off to mom. Now we have the cord ready to clamp and cut. We would have a 60-second delay. The nurses will let you know how long that is when that's ready. You're going to take your cord. We're going to take the yellow clamp. It's going to be the clamp closest to baby. We're going to clamp that on there. For this point, I'm going to do it just for demo. That clamp is clamped close to the baby. And if you're ever concerned, leave it longer. Longer is fine. The nurses will come back and trim it. That clamp is on. The yellow clamp, you can hold on to that. You're going to milk down. Put your clamp on with the tips facing downward. We've milked that cord so that we get as much blood out of it as possible so that dad can now cut the cord. Now we have a baby that's delivered. Mom's going to have the baby. Now we're going to deliver the placenta. This is going to be your role. You can take a bucket, place it between your hip and the bed. You're going to collect your blood sample. Your job is to take the end of that umbilical cord, put it into the end of the syringe with the numbers on it. That's the side that the blood goes in. 6, 8, 10, full to the top, any of that will be fine. Put it into the end of the syringe. Loosen your clamp. Be careful because this can squirt all over the place. Many times the nurses are shielding their eyes. We're going to try and collect that blood, reclamp the cord, and then take this tube and let your nurses know, I have your cord blood. Usually they're very quick to pick it up and take it. Now you have your end of your cord. This is representing your vagina with your pelvis. You've got the end of the cord in your bucket, trying to catch any blood or fluid that's coming. You can take your clamp, unclamp it, and put it closer to the introitus in a downward facing direction. This gives you a very nice handle to put 2 fingers to be able to put traction on that cord. The amount of traction is a skill. The residents will help you, not too much, not too little. We will help you do that. Oftentimes people will do it in a circular fashion, see if that cord is lengthening. I've learned to do it in a C fashion. The residents will assist you with that. You have 2 things that help you know whether or not that placenta has detached from the uterus and is ready to deliver. What are those 2 things?
Lengthening of the cord, a gush of blood.
How long do you have to wait until that placenta delivers?
30 minutes.
Excellent. So we're going to see if this placenta is coming. I want you to take your hand, put it above the symphysis. This does represent the patient's symphysis, and sometimes you have to really get in there to be able to feel it. You're going to give that cord a tug. When you tug it, if you feel the uterus come onto your hand, that's because the placenta hasn't detached. We can give it a few more minutes. During that time, we can look and see if this is the introitus, if there's any repairs that have to be done in this area, if there's any lacerations, we can check the entire area. We can call for suture. The nurses will get our suture. The residents will help you with that. What suture do you want? What size do you want? We're going to do that while we're waiting. We're going to try again. You're going to give a gentle tug. Do you feel it this time? No, the cord's lengthening. You can stop at this point if you'd like and bring your clamp back up to the introitus. Again, in a downward facing fashion. Again, that gives you a nice 2-finger hold on your clamp. When you pull on the cord, we're not feeling any uterus movement up above. That placenta is let go. Let your nurse know that the placenta is delivering. She's going to start running your Pitocin. And as it comes out, if you can roll it up with the membrane, start to do a roll or a twist so that you can twist your membranes. It's one technique to try and ensure that all of the membranes coming out of the introitus are coming in one chunk as well. What we don't want to see is that any of this is starting to shred. If you feel it's shredding, those membranes are shredding, let your resident know. They will help you with it. We do not want any left in the uterus. That's one of the major reasons that we will have postpartum hemorrhage. All of it, as we twist it, hopefully will plop into the bucket as one piece. We can put the bucket off to the back, wherever you'd like. As we come back, address any bleeding that's happening. That will be the resident helping you control any bleeding. Uterine fundal massage is your best friend, and when you do that massage, it is every bit of pressure that you can get on that uterus. The uterus should be in the center of the abdomen. It should be hopefully at or below the umbilicus of the patient, and it should basically feel like a softball. That's our goal. If it's not, we're going to be rubbing on that uterus. Very often the residents will do a bimanual so that they're holding the cervix in one hand, the uterus, the top of the uterus in the other hand through the abdomen, and doing a bimanual massage of that uterus. You will frequently see that, removing any clots that go as that happens if need be, until we get a nice firm uterus and the bleeding is controlled. We look forward to seeing you soon.